atrial rhythms. And you can follow along in your book if you want. Okay, atrial rhythms, the origin is somewhere in the atrium, right? Somewhere in there. And there are a few rhythms that we're going to be looking at specifically. The wandering atrial pacemaker, we shorten that to WAC. Multifocal atrial tachycardia, MAT. Premature atrial contractions, which is going to be TAC. We're going to look at atrial flutter. That's kind of interesting. I like the way that looks. Atrial fibrillation, call that AFib. We're going to be looking at SVT. And we're going to be looking at Wolff, Parkinson, and White, which is WPW. So all of those come with a little initial, so that's going to make it easier for all of us. So we're going to look at identifying those on the EKG strip and how they vary, and we're going to be looking at the clinical significance of the atrial rhythms. So you know just by the fact that it's in the atrium somewhere, that it doesn't generate in one of the normal nodes, so we know that all of these are going to be problematic. Okay, we said they're all identified by their site of origin. So if it says that the site is somewhere in one of the atria, what is the QRS complex going to look like? It should be narrow because it's above the ventricles. But let's see what all we have here. So why would we have an atrial rhythm instead of a sinus rhythm? Yeah, if the sinus rhythm is not firing right, something's wrong with it, then it's not going to generate its impulse. All right, these are atrial dysrhythmias. They're usually not life-threatening, but you're going to have to continuously monitor your patient. Oh, it's you, hey! Got here just in time for Chapter 8. All right. See where we are. So we're looking at the pacemaker sites. You remember the intrinsic rates for the SA node is 60 to 100, the AV node 40 to 60, and bundle piss 20 to 40. All right, got past that screen. Okay, so we need to get a definition now of an ectopic beat. An ectopic beat occurs whenever the impulse that generates it does not occur in the SA node, in the normal node. Sometimes they're premature beats, sometimes they're late. Most commonly they're going to be premature, and they usually occur early in the cycle, before the SA node would normally discharge. Now sometimes you've got a normal discharge of the SA node, but you also have these ectopic beats. With most of the ectopic beats, we can identify them and we can name the rhythm. Every now and then you're going to get what we call FLBs, funny little beats that can't anybody figure out what they are. But for the most part, we can identify them. So anytime we get a complex that's generated that's not from the SA node, we're going to call that an ectopic focus. Ectopic beat is something that's out of the norm. It occurs in a site that's not a normal pacemaker site. Call that ectopic, an ectopic beat. So y'all got that? Yeah, we got that. Some of you guys are real visual. You might be able to pick up on this. I'm not visual, so I have a hard time following it myself. You can look at these P waves. This P wave, we have probably a little bit long PR interval here. Here it's really tight. The shape is a little bit different. This one's flat on top. That one's round. What about this one? It's inverted. What about this one? It's kind of peaked, isn't it? Here, that one looks like the first one here. That one looks, the PR interval's too long. But these drawings here show the ectopic focus. You know, normally it would start at the SA node and go down, but here they're just showing that the ectopic focus is somewhere other than where it should be. And the further away it is from the SA node, the longer PR interval you should have normally, because it takes it a while to get down to the SA node. So it's going to be elongated. So if the site is anywhere other than the SA node, then we're going to call it a ectopic beat. Now here specifically is what we call a wandering atrial pacemaker, a WAP. And you identify that because each one of the P's are different. They're not originating from the same site. Now for instance, if this site, which has generated this P wave complex, if all the irregular beats came there, what is the complex going to look like? It's going to look the same. Right, so here you can see that there are a lot of different ectopic sites. So we call that wandering. You know, the energy is wandering around and it's finding a cell that it's going to excite and generate this, the movement. So it's moving around. We call that wandering atrial pacemaker. Usually, you know, this isn't going to kill your patient, but you do have to be able to identify the rhythm. Now, for it to be a WAP, it's got to have at least 3 different complex, 3 different shaped P waves. So when we use this, these 5 things when we're trying to identify our rhythm, when we're looking at the P wave, we say they're upright and the same across the strip. That's what we're looking for. But you're looking at the shape of the P wave. If the shape of the P wave is significantly different, then you've got a wandering atrial focus. But you got to have at least 3 different for you to call it a WAP. And the shape, the size of the P wave is going to vary based on how far it is from the SA node, how close it is to the AV node, that sort of thing. Because we don't really identify that. We just identify that they've got different shapes. The P waves can come in just about any fashion. They can be inverted. They can be upright. You could actually have a case where you can't see the P wave. But if you look at all the rest of your rhythm, you've got sinus rhythm with different P waves. Even if you have an absent P wave, that may mean that it's buried in the larger complex, which has more energy, so it buries it. You can't see it. Absent P wave means it's buried. You already said that. So the PR interval may be normal or it may be abnormal. It may be elongated. It may be very close, depending on where the focus is. So don't be thrown off if it's a regular PR interval. You're looking for the shape of the P wave. Y'all following me okay? Sometimes I'm getting some stares, like, what's she talking about? We'll see some pictures of this in just a minute. Most of the time, as I said at the beginning, your patient's going to be asymptomatic from this. As long as they're getting a normal QRS and it's an adequate rate, usually they are asymptomatic. So the rate usually is good. The rhythm is, it could be slightly irregular based on the length of the PR interval. But for the most part, it stays relatively regular. So the only thing you're probably going to notice with a WAP is the P wave is shaped odd. All right, got to start here. Get ready. A wandering atrial pacemaker can have an inverted P wave. True or false? This is 100%, I hope. I think next time I'm going to really hand these out so I know who's voting how. Oh, good job. Probably send this. Oh, yay. Yes, finally. Good job. Okay, here's a picture of a wandering atrial pacemaker. So look at those P waves. Do you see any that are absent? Is it absent or is it just like really small?
Really small.
Yeah, really small. You see, how about the PR intervals? Are they all normal? They're probably within normal limits. Some a little bit longer than others. Yeah. But is the rhythm regular or irregular? So be regular. What's the rate? Yeah, it's within normal limits. Yeah, so would you call this a normal sinus rhythm? It's not really a sinus rhythm, is it? Call it WAP. Not killing your patient. Okay, look at this one. Is that the same one? No, it's a different one. Look at the P waves, look at the PR intervals. Is this regular, irregular? What's the rate? Is it regular, irregular? Yeah, I think it's pretty regular. Maybe a slight irregularity on the second one to the third one. Maybe that's a little wide, but not enough to change it. P waves? Upright and uniform? No. You got some upright. Do we have any that are buried? Where? Yeah, the third complex is buried. How about fourth, fifth, and sixth, and seventh? Inverted, that's right.
How would you know the third one's buried versus absent? Same thing?
Well, because they're being generated, you've got a QRS complex. And because this is tight, you know that it's getting its impulse from the atria somewhere.
So it has to contract.
Yeah, it's going to contract. It won't contract if it doesn't get that energy.
Right.
So you know that it's getting it, you just can't see the P wave. That's a good question. All right, let's see. You recognize a wandering atrial pacemaker because of the, there's only one correct answer here.
Like registry. One is right, really right.
Yeah, one's more right. How's that? I had 24 last time. Who's not playing? Okay, does a WAP always have an inverted P wave? No. This is a registry type question. It can have an inverted P wave, it doesn't always. It can have an extended PRI, but not always. Always it's going to have a variable P wave. So that's what makes D the correct answer there. And thanks for nobody putting YQRS. I appreciate that. Okay, the next rhythm we're looking at is the MAT, multifocal atrial tachycardia. What do you think the multifocal means? Yep, same sort of thing. The focus is going to be from a lot of different areas. Because it says tachycardia, we know what? It's going to be fast. It's going to be over 100. We see this in patients very ill with COPD. If they have some type of toxicity from digitalis, we see a lot. Of course, actually, they don't use digitalis quite as much as they used to. Electrolyte imbalances can lead to this. Here is, I put both of these up so you can see the differences. This is multifocal atrial tachycardia. Look at those P waves. Every single one of these complexes has a P wave, doesn't it? Yes. Is it upright? Yes. Are they uniform? No. Multifocal, that means they come from different foci around the atrium. This is a atrial fibrillation, and we've not talked about that yet, but I wanted you to see the difference. Here you see P waves. Here you do not see P waves. That's going to be the main difference between those two. Yeah?
I guess maybe 1, 2, 3, keep going. Is that 2 atrial beats there?
No, that's just, this is where you're repolarizing and it's late. This one's early, so it jams it close.
Jams it. Okay.
Yeah. Yeah, it looks like 2 P waves, but it's not really. This is this,
That's
only it's closer.
Wave.
Yeah. Good question. So for some reason, atrial fibrillation is the strip that more students miss than just about anything else out there except third-degree heart block. But P waves, we're going to call it atrial something. We can see these P waves, so you know it's above the ventricles. Here, you don't see any P waves because they're not really generating them like they should. But we'll talk about that. So I just wanted you to see those two. So multifocal atrial tachycardia. The key to identifying this is going to be looking at the P waves. Same thing with what we're just looking at. You look at the P waves, look at the shape. Are they upright? Are they always upright? If they're inverted, then we're not looking at multifocal atrial tachycardia. All right, y'all ready for a quiz? Besides the rate, the difference between multifocal atrial tachycardia and atrial fibrillation is, I'm looking for 100% here. See how long you can hold a thought. Come on, a few more. Chop, chop, chop. You're going to learn to think under pressure. Well, somebody didn't vote. Okay, this is very interesting. The answer is presence of the P wave. Let's back up here. Atrial fibrillation is always going to be irregular. There's no other thing. It's always going to be irregular. However, the P wave, is that the answer here? Question? The P wave is the difference. In atrial fib, there's never a P wave. You can't identify a P wave. We'll get to that. So the difference in these two is going to be the P wave. We're talking about P waves here. So MAT is irregular, atrial fib is irregular. They're both irregular. The difference between the two is going to be the P wave. All right. Premature atrial contractions, PACs, a generally innocuous little beat. It's a single electrical impulse. It originates outside of the SA node. This also is an ectopic beat. Anything that doesn't come down the normal pathway is going to be called atopic. Now, an ectopic beat is anything that is outside of the normal node. So if we say we have a premature atrial contraction, where is that occurring? Yep, it's going to be above the ventricles. What's the QRS going to look like? Yep, it's going to be narrow. It's going to be tight because this is generated, any rhythm that's generated above the ventricles, like in the atria, is going to be tight. With a premature beat, what does that mean? The complex, the whole complex is going to be jammed up closer to the prior complex. So it occurs earlier rather than later. Now, I do want you to understand one thing about these complexes that we're seeing. They only represent electrical activity. It doesn't represent contraction of the heart. Can you think of a circumstance where you've got nice electrical activity, but the heart's not contracting? Do what? PEA, pulseless electrical activity. Yeah, so what we're looking at is electrical activity. It doesn't necessarily mean that there is mechanical activity too. Just want you to know that. We should call all these complexes, like PACs, we call it contractions, but it really is a complex. It's a premature complex, so we'll look at those here in just a second. And after you have the PAC, there's usually what they call a non-compensatory pause, where there's kind of a pause before the next one starts back up. The underlying rate is usually going to look like a sinus rhythm, because it is a sinus rhythm, with these occasional thrown in ectopic beats. So we'll look at this. When you look at a PAC, the rate is usually normal. The normal limits for a sinus rhythm. It's usually regular, except it may have one of these ectopic beats. You usually don't see a lot of them with PACs. You're not going to get a bunch of PACs in a row. The P waves are going to look a little bit different than your normal P waves. But the biggest thing that you're going to notice is going to be the PR interval and then the regularity of the rhythm. The underlying rate is usually regular, so we're going to name it by its underlying rate, correct? So let's see if I have, I don't have a picture up there. We'll get there. Compensatory versus non-compensatory. I put this up here because I wanted you to understand it, because your book just kind of glosses over it. With non-compensatory, the normal beat following the premature complex occurs before it was expected. So sometimes it keeps a regular rhythm and there's just this dropped beat that almost looks like, well, if you see the ectopic beat, it's close, but if you moved it over, it would be in a normal, it would look like a normal sinus rhythm. With a compensatory, the normal beat following the complex occurs at the expected distance. That means the body's compensated for it and it looks real regular. It would be regular if you just slid that over. Non-compensatory, there's going to be an extra pause there where the body hasn't compensated for that ectopic beat. Does that make sense? Y'all can think about it. You can ask me and I'll explain it later on if you want. Okay, this is, where's the PAC here? Yep, right here. Look at the shape of the P wave and the PR interval compared to the others. Yep, it's upright, but it's shaped a little bit different. The PR interval is a little bit longer, and you can see that it's closer. So when you look at this rhythm, you would say it's irregular, but what's the underlying rhythm? Look at this complex. You've got a normal P wave, it's probably got a normal PR interval, upright and tight for the QRS complex. All these others are normal. This is your funky beat. That's going to be a PAC, premature atrial contraction. What that means is the complex came too early. This usually is asymptomatic. Patient never knows it. Any one of you guys can have this and you never know it. Good question. Let's look at it. Would this be compensatory or non-compensatory? Non? How are you going to figure out the difference? If you move this thing over, it should almost go just like a normal beat if you moved it over here. If you moved it right in the middle of these two, would it be the same R to R? Think so? I'd have to measure it out to be sure. Does it really matter? It doesn't really matter. I just wanted you to understand compensatory, non-compensatory. So if this was like way over here, it was a longer interval before it picked up, then it would be non-compensatory. But if it would slide in right here and look pretty much normal, then the body's compensated and made up for it. Kept on going.
The book says that's non-compensatory.
It does say that? Okay, then it's non-compensatory. I can't see unless I move it over and look at it. All right. Okay, some other little terminology that you need to know about. We'll talk about bigeminy, couplets, and trigeminy a little bit later, but it was easy to put it in here now. If you look at this strip, you see little groupings, right? These, you could call this, if it's every other beat where one has come in, then we've got bigeminy. That means every other one. So this is a normal beat, premature. Normal beat, premature. Normal beat, premature, just like that. So we'll call that bigeminy. With trigeminy, you can see it's every third one. Normal beat, screwed up beat. Normal beat, screwed up beat. Here it is, normal, screwed up. That's right. Normal, screwed up. Normal, screwed up. Does that make sense? Every third one is going to be your PAC. Actually, this is a PAC. It should occur here, but it's premature. It should have occurred here, but it came premature. So it's every third one is premature. So we're going to call that. We call that atrial trigeminy. Yeah, it is a PAC, but when you say atrial trigeminy, you're talking about PACs. So this is not a big deal. It's just if you see it and there's a pattern there, we just name patterns. That's just kind of what we do. Okay. So with PACs, you're going to identify the underlying rhythm. So you're going to call it a sinus rhythm with PACs. Yeah. Or it could be a sinus rhythm with trigeminy PACs or bigeminy. Causes of premature atrial complexes usually are going to be stimulants. You know, if you're taking a lot of caffeine and stuff like that. It could be an excited stage where you have some type of increased sympathetic tone for whatever reason. Digitalis, you can always blame anything for that. Electrolyte imbalances. Now, anytime you have an ectopic beat where you get more than 6 in 1 minute, then we're going to call that frequent. So patients become more symptomatic if they've got more than 6 ectopic beats in a minute. Now, PACs still, even when you've got 6 or more in there, they're usually not lethal by any stretch. Whereas if you get a lot of PVCs like that, then you've got something else going on. Re-entry dysrhythmias. I hate these. Really, a re-entry dysrhythmia, what that means is there's an excited area and it goes down, it's trying to pass that stimulus along, but there's something there blocking it. So it backs back around and it still wants to go to that same place. So it backs around and tries to go through it. So it kind of gets a spinning motion. We call that a re-entry dysrhythmia or complex. But the same impulse is circling around and it keeps exciting the same place. So I hate these old pictures. Maybe these pictures make sense to you. But it can, because it's delayed, you know, it comes down, it goes here, can't get through. What could cause this not to get through? Yeah, if you've got damaged tissue here, what type of patients might have damaged tissue? Yeah, if they've had a prior heart attack, they've got dead tissue here. It might swing around like this and go back, and it just kind of circles around. It just keeps exciting that one area. So this is important as we're moving along here. It kind of short circuits. Okay. So the impulse just kind of circles around. Only goes in this one direction, going around and around somehow. So this causes a lot of our tachycardias. It causes, because it's just circling and it keeps, it doesn't have time to spread throughout the rest of the heart. It circles right up there and keeps irritating it, causing it to fire. Another picture here. Is this a atrial rhythm or sinus rhythm, or is this a ventricular rhythm? It's sinus because you can see the P wave. And you know it's not a ventricular rhythm because, yeah, when you've got a QRS that looks like a hairpin like this, then you know it's not generating in the ventricles. So you can't call it ventricular anything. All right. Okay, things that can cause this reentry, as we said, of course, myocardial ischemia, infarction. If you're on antidysrhythmic medications, that sometimes can cause this. Hypokalemia. Some of the rhythms that we're going to see that are generated with this reentry may be atrial flutter, atrial fib, PACs. What's paroxysmal supraventricular tachycardia? What's paroxysmal mean? Do what? Close to, it kind of sounds like that, doesn't it? Paroxysmal usually has a quick start and a quick end. You can identify when it started and you identify when it ended. It kind of has a short life. So paroxysmal, it comes on suddenly and then it goes away suddenly. Okay, atrial flutter. I love this rhythm. It's just kind of pretty-like. We do not see it very frequently, not as much as we see atrial fib and some of the others. So it's not, you don't see it frequently, but when you see it, you usually recognize it. It's very attractive. It has a very sawtooth pattern to the P waves. With atrial flutter, it's got one ectopic site, or one re-entry that keeps irritating the same place. And because it's the same place, the complexes that it generates look the same, right? You know, with WAP, wandering atrial pacemaker, you've got different ectopic sites, different sites that are irritated and cause a complex. With this, it's the same place that keeps getting irritated. And because it's a re-entry, it is very fast. You don't see a normal P wave there. A normal P wave is going to be generated from where? The SA node, right. So we won't see a normal P wave. But it is very fast. This is, yeah. This is atrial flutter. You can see the little sawtooth look to it. And there'll be variations of this, but these will be very rhythmic, and I think they're very easy to identify. We don't call these P waves, we call these F waves. And F doesn't stand for flutter waves. I know you think it does, but for some reason it doesn't really. But we call them flutter waves, F waves, but they're very rhythmic. And one of the things that you're looking for, these are P waves, so the F waves right through here, there are two of those, but only one of those is generating a complex, right? A QRS. So we'll call this a 2-to-1 conduction. There are 2 flutter waves for every complex, 2-to-1. So at this point, if you think about the AV node, where's the AV node? What does it do? Yeah, it picks up the impulse from the SA node, it collects it, it holds it, and then it generates it, sends it down to the bundle of His. So it's like a gatekeeper. It decides what it's going to get through and what's not. Usually it's very regular with what it lets through. With atrial flutter, it's usually pretty regular. Usually, not always. Here is a 4-to-1 conduction. You can see we got, this is an inverted one, but 1, 2, 3, like 1, 2, 3, and then your QRS. 1, 2, 3, QRS. 1, 2, 3, QRS. Well, actually, I guess that's 4. Yeah, they're calling that 1, 2. Yeah. So it doesn't exactly look like these. Why does it not look like these? Huh? No, think about it. Did Nick give you all the toilet flushing thing when he described how these things repolarize? Yeah, here. You're getting in right the tail of the refractory period, and it hasn't totally repolarized, so you're not going to get a normal looking one there. Okay, so that's a 4-to-1 conduction. Now this is not talking about this one. With a 2-to-1, you see 2 contractions. 3-to-1, there are 3 contractions before complex, and 4-to-1. You also want to look at the atrial rate. Here, if all of these were conducted, you'd have a rate over 300, but they're not all conducted, right? Thank goodness. At this rate, you can look at them 1, 2, 3, 4, 5, 6, 7, 8. So the rate's about 80 in there. But if all those were conducted, the atrial rate is different than the ventricular rate. So if you were figuring out the atrial rate, you'd count these off, and you'd have a rate of over 300. Ventricular rate is about 80. So with flutter, it's going to slow down the ventricular response because not all those P waves or F waves are conducted. So usually the ventricular rate is going to be quite a bit slower, hopefully. Now you could have, like with a 2-to-1 conduction, you could have a rapid ventricular rate. So you could have a flutter where they're almost bradycardic. Say it was like a 5-to-1 or 6-to-1 conduction. So you've got all those F waves, and then finally, on the 6th one, it's conducted through. They're going to be bradycardic, right? Well, if every other one is conducted through, you could stand to have a very fast ventricular rate. So we're going to treat those differently. So let's look at the 5 rules that we have over here. With a flutter, is it regular or irregular? I mean the rate. The rate's going to be different. You're going to have a different ventricular rate than you have the atrial rate. It may be variable or it may be fairly regular. P wave before every QRS, they're not P waves, they're what? They're F waves. And you should have at least one F wave before every QRS, and depending on how it's conducted. The length of the PR interval, do you think you can measure those? Usually those flutter waves are right up next to that QRS complex, so you're not going to be able to measure that. And then what should the ventricular complex look like? Yeah, it should be narrow. It should be less than 0.12. So with a flutter, there aren't any normal P waves. They're going to be flutter waves. All right, both of these are flutter. What do you think the conduction ratio is here? Yep, 3-to-1 and then 2-to-1. So count the rates. Which one's going to be faster? The quicker they're conducted, you know, if a 2-to-1 is going to be faster than a 3-to-1. 3-to-1 is going to be faster than a 6-to-1 or whatever. But you can easily see those flutter waves, can't you, the F waves? Those are easy to identify. And you can see, this is going to be pretty regular. One of the ways you'll identify that. Okay, let's move to AFib, atrial fibrillation. If I don't get anything else through to you, number one, it's always irregular. Always is a big word here. AFib is always irregular. The second thing is there are no identifiable P waves. What's happening in the atrium for AFib is there are 1,000 ectopic foci in there. Thousands. And that's why you get all this gibberish down here. No P waves there. Is that irregular? Absolutely is. One of the ways that if we start watching these in a dynamic fashion when we're identifying them as they're going across a monitor, one of the first things you're going to look for is it regular or irregular. If it's irregular, that's going to put out normal sinus rhythm. There's a lot of rhythms that you can set aside because it's either regular or irregular. So I always divide my rhythms into regular and irregular, and then I go from there. So AFib is always irregular. Another thing you can do when you're looking at AFib or looking at a strip, if you kind of squint your eyes down, like sometimes students will go, I think I see a P wave in there. There really isn't one. But if you kind of squint your eyes down, if there's a P wave in there, it should hold its form. But you don't see a P wave there. Don't make this harder than it is. If it's irregular and you see squiggly lines, it's what? AFib. All right. One of the most common atrial dysrhythmias. We see this a lot in your elderly population. For some reason, they just get a lot of AFib. A lot of times it has to do with problems with the sinus node, electrolyte imbalances, things of that sort. But it's not uncommon at all. There are some things we're going to want to know about it, like is it an acute onset, a new onset, or if it's something they regularly have a problem with. How could you identify if it's an acute onset or a pre-occurring, one that they deal with all the time? Yeah, if they take medication for it, then they've been diagnosed, they're treated for it. If you say, it looks like you've got AFib, and they've never heard of it, and they don't take any cardiac meds for it, then it would be a new onset. We're going to treat those differently. So there's a notable absence of P waves. We don't see any P waves here. Some of these things, if you start to try to identify something, they're going to be F waves. Like if you looked at that, oh yeah, there's something there. They may be F waves. F waves. Can't speak today. This is what we call irregularly irregular. We'll talk about regularly irregular and irregularly irregular. Does that make sense? Yeah, yes and no. This is always going to be irregular. Always. And there's not going to be any kind of pattern to it. AFib is irregularly irregular. It is always irregular. There's never any kind of pattern to it. But what does a QRS look like? It's tight. So where is the impulse generated from? The atrium, above the ventricles.
What does the X stand for?
Well, I don't know what it stands for. They just gave it a name. Like the T wave is just a T wave, and it doesn't really mean anything. P wave, they just call it the P wave, and it doesn't mean anything. They call these F waves, but it doesn't really stand for flutter, because we do see it in other complexes. So anything that's weird like that, they call it F wave. If it's not a P wave, then they...
Fibrillatory waves.
They're what?
Fibrillatory waves.
Fibrillatory waves. You know, I have a hard time identifying a F wave on atrial flutter as, what do you call it?
Fibrillatory.
Yeah, it's not really fibrillatory, I don't think. But anyway, so there you go. Is that the big book? Yeah, I haven't read the big book. Okay.
The workbook is the workbook.
Oh,
On
see.
top of the big.
Yeah, I haven't read it either. Well, we got the new edition. I just didn't get mine until last week. So anyway, with AFib, as I said, you've got a zillion different foci in there. They're like blitzing. That's a good word. I like that. They're blitzing. Some get through, and there's no pattern to when they get through the AV node. Because there's so many bombarding the AV node, you know, occasionally one will get through. It just doesn't know what to do. So it does what it wants. It's very random. So AFib, you're going to look at the atrial rate and the ventricular rate. We really can't count the atrial rate because we don't see any real waves there. But we can count the ventricular rate usually. So it's irregular. P waves are absent. We call those F waves. We can't measure the PR interval because there's not a PR interval, right? And the QRSs are going to be what? Upright and tight. All right, AFib is always irregular, true or false? If you miss this, I'm taking names. This is the real thing. Come on, a couple more if you haven't voted yet. You're afraid you're going to get it wrong? I'm going to tell you. Always irregular. AFib. Can you see P waves in here? Those are F waves in there. You may see this and think that's a P wave. You can't measure a PR interval there, can you? Not really. There's no line there. It just happened to land there and look almost like a P wave, but that's an accident. So is this regular or irregular? It's actually irregular, isn't it? There's no pattern at all. If you could see couplets, is that regular? Is it regular, or is it regularly irregular, or irregularly irregular? It's irregularly irregular because there's no pattern. All right, AFib, what have we got here? Another example of AFib. Now, why is this not flutter? Those Those look kind of pointed to me. Some of them do. It's probably within normal limits, though. If you measured it, probably within normal limits. I'd have to get out my stuff. But it's definitely not regular. You can't identify any type of P wave or consistent F waves that kind of look alike. So that's fun. Okay, with some people, some of your patients always have AFib. That's just their life. They're going to take anticoagulants of some sort because when you've got that type of fibrillation, you've got blood that's squishing around in there and not moving normally. When it just stays around and circulates, there's a much greater chance that you're going to get blood clots there. So they're always going to be on aspirin or some other regime of some sort. We see this with patients that had rheumatic heart disease, who had a rheumatic fever as a child, which I think that's almost been obliterated. When I was young, people had it. CHF may have AFib, so a lot of your patients, probably over the age of about 60, you're going to see a lot of AFib. Hypoxia can cause it, DIG, of course. I mentioned electrolyte imbalances. Treatment, how are you going to treat this? Okay, pull open your little things. What is AFib listed? Is that going to be under tachycardia? See what you can find in there. AFib could be bradycardic or it could be tachycardic. So depending on if it's bradycardic or tachycardic will indicate which one of these you're going to go to. Partisan? What page are you on? I'm not in the workbook. Let's see what I have here. The biggest thing you're going to do is monitor your patient to see if they're stable or unstable. If they're unstable, then we have to look at some other stuff. If the heart rate is slow, I got their slow heart rate. Over 100 is rapid. If it's slow or if it's fast, may indicate how you're going to treat this. We don't use digitalis on the ambulances. Thank goodness. You'd probably kill a lot of people. But what else might we do outside of medications for this? Do what? A little bit of outbound power here, maybe. You may use cardioversion, synchronized cardioversion, if the heart rate is really fast. We don't do that for bradycardia, of course. But if your patient was symptomatic and they were bradycardic, we got medications that we use. What's the most common medication or our first-line medication after oxygen for bradycardia? Atropine, that's right. If they're unresponsive to atropine and they're very symptomatic, what are you going to do? What? Did I hear it? Yeah, we're going to pace them would probably be next. But you may also consider dopamine. So it really depends on how your patient is. If they're very symptomatic, I'm going to pace them. If I feel like I've got time, I may hang a dopamine drip. All right, y'all got that? Oh, I had a question. Did I have a star up there? I did. Which of the following rhythms have sawtooth waves? Yeah, we're going to make this. All right, come on, y'all. Remove somebody. Oh, I did have a time. Shoot. Da, 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 da. Pick that. I'm sure it was an accident. Sawtooth waves, F waves, flutter waves. Okay, let's talk about SVT. Supraventricular tachycardia. Supra means what? Supra. Tachycardia means fast. This means above. So this is going to be above the ventricles. And they can't really identify where the focus is on here. So if you can't identify it, SVT is an umbrella term. Now, I will tell you that on a test, our test, or on National Registry, if there's a P wave on there that's identifiable, it's not SVT. If there's a P wave on there, it's what? It's a sinus rhythm. So look on there and make sure that you can or can't see a P wave. So anything that's over 100 which is unidentifiable, we're going to call it SVT. If it's, you know, how can we tell it's SVT and not, you know, VTAC? Narrow complex. If this is narrow here, this is pointing where? It's pointing above the ventricles. If it's narrow like this, it's above the ventricle. So don't call this, do not call this VTAC. I can't tell you the number of students that have called this VTAC. I will hunt you down, and we're going to get out our crayons and we're going to draw little complexes, okay? All right, so this is above the ventricles. Paroxysmal, as I said, is this paroxysmal? Well, by us looking at it, can we see that it's paroxysmal or not? If this is all we have, this is not paroxysmal. Paroxysmal has a definite start and a definite stop. It may be intermittent, but it's a sudden onset or sudden cessation. So you may have a patient that's in SVT, and you get them to cough or do something and they break it, and then they go into a normal sinus rhythm. That would be paroxysmal. All right, you got that? Okay. In this case, this also is a re-entry type rhythm, and this totally overrides the SA node. You could have the SA node trying to do its thing, but you get this ectopic focus, and it overrides the SA node, and it becomes the primary pacemaker. It says, I'm in charge, I'm bigger, I'm faster, I'm stronger. It can look like sinus tach, but sinus tach has what? P wave. SVT, no identifiable P wave. Usually sinus tach, you may be able to see it up to 160, you know, maybe even 170 if you can see that P wave. But if you look at the rate, if it's over 200, it's going to be SVT. You're probably not going to be able to see a P wave. So look at the rate to help you identify what it is. If the rate is 140, what is it? It's sinus tach, because at 140, you can see a P wave. All right, the rate. The atrial rate is much faster, usually, than the ventricular rate. Oftentimes there's a buried little focus in there somewhere. The rhythm is regular, can't see a P wave. The PR interval is, you can't measure that. Do the QRS complexes look alike? You bet, they're all upright and tight, right? All right. Here's a couple of SVTs. Which one's faster? Is the bottom one, is that a P wave you see? I know it's not as clear for you as it is for me. This little thing right here is not a P wave. That is just as your complex is starting. That's not a P wave there. They're both fast. They're both SVTs. Okay. SVT can be caused by stress, overexertion, hypoxia, stimulants. We see it a lot with different types of stimulants, hypokalemia. Treatment. You may try vagal maneuvers first. If you don't put vagal maneuvers first, then you're probably going to be counted wrong here. So always start with vagal maneuvers. How can you, what would be an example of a vagal maneuver? Somebody?
Bear down.
Yeah, if you tell your patient to bear down, and of course stay clear, because sometimes they're bearing down, it's ugly. Because we're going to stimulate the vagus nerve, and when we stimulate the vagus nerve, what's the response in our body? Sympathetic, parasympathetic? Parasympathetic, that's right, and that's what we want. It sometimes works, sometimes doesn't. Do y'all understand the role of acetylcholine in the whole working of the nervous complexes here? Yeah, do you know how it works? No? Well, acetylcholine is one of the things that after the impulse goes through, it goes through and resets everything. So what's happening when these really fast rates, sometimes there's not enough acetylcholine in there, and so it just zooms right through. But if you get a parasympathetic response, it'll release acetylcholine, and it allows it to relax that before the next one goes through. Did y'all not do that in farm? No? Okay. All right, bear down, coughing, squatting, some type of physical exertion like that. We don't do carotid sinus massage, so don't start massaging that. But coughing and bearing down, with a young child, a younger person, what could you do if they don't understand bearing down?
Hold his breath.
Do what?
Kind of hold his breath.
That's a possibility if you can get them to really hold their breath hard. Cold water to the face, cold washcloth. I didn't mean throw ice water in their face, but. Okay, therapy, how we're going to manage this. What are we looking for, even with SVT? What's going to be the important component that we're looking for before we decide how we're going to treat this? Are they stable or not? How sympathetic, how symptomatic are they? How would you determine if they were symptomatic from SVT? Well, you're going to do your assessment, but what signs and symptoms are you looking for? Yeah, they're always going to show signs of shock, probably, but one of the main things you're going to be looking for is blood pressure. If their blood pressure is good, they're perfusing. If the blood pressure is bad, they're not perfusing. So always use blood pressure as one of your leading things. Mental status, as well as skin signs. But anytime you get an altered mental status, or you've got a bad low blood pressure, then you may bypass even adenosine. Usually adenosine is going to be our first line medication, because you already got your IV in place, right? You already got your oxygen in place. But adenosine is what we use for SVT. Anybody know how adenosine works? Yeah, what it does is it puts you in cardiac arrest. And if you guys ever used any adenosine on a patient, or you've seen it used? Yeah, use that adenosine, and all of a sudden your patient's in cardiac arrest for a couple seconds, and you're going, oh, please, Jesus, if you're ever going to start one back, do it today. And then that complex comes back. So, but you'll see that period of asystole. So it actually stops the heart and allows it to reset. It's always a scary time. The other way that we restart the heart is how? Yeah, we light that patient up. So if they're very symptomatic, I may not waste time. Like if they've gone unconscious, they're getting some power right then. You're not going to waste time with adenosine. But adenosine would be your front line if your patient has a decent mental status. And then after that, we'll go to synchronized cardioversion. Synchronized cardioversion is a lot safer than unsynchronized cardioversion. What would be a form of unsynchronized cardioversion? Well, defibrillation, yeah. Just wide open defibrillation. What is the dosage for adenosine? 6 and 12. In the old days it was 6, 12, 12. Most of the time, do what?
They took the second 12 out.
Yeah. Well, usually they convert on the first 12. They should just start with 12. I don't know why they don't, but they go 6 and what's 6 what?
Milligrams.
6 milligrams. Anybody that you're using adenosine on, it's going to go 6, 12, 12. Now, when you use adenosine, what vein do you want to use? Anyone you get? You want the AC?
Closest to the heart.
Yep. Number one, you want to be close to the heart. So for us, the AC or EJ. Who's getting the EJ? Unconscious people. Don't stick a conscious person, please. They'll never like it. But yeah, you want to be close to the heart, because what's the half-life of adenosine?
10 seconds.
Yeah, it's really fast. You're talking about 5 to 10 seconds. Probably more like 5. It's really quick. So you want to be close to the vein.
We got called out.
Y'all are in the corner. See, you're like fresh meat back there. I can see you. Yeah, with adenosine, it has a short half-life, so you got to get it to the heart as quickly as possible. So what we usually do, you're going to go with the vein, probably the AC. If they're unconscious, you've probably got an EJ here, which is pretty quick too. And you want to follow it with a quick flush. When you're doing this, you've already got your fluid hanging, or you've got at least 10 cc's or more of fluid. We usually use a 2-syringe method, where you put it in your IV and you hit your adenosine and you hit that right after it, and it kind of pushes it to the heart. So it works very rapidly, so you should see a conversion pretty quickly. If you do 6 milligrams, it doesn't work, you're going to follow it with 12. If that doesn't work, what are we going to do? Lighten them up. Yes, sir. Okay, the top heart rate for sinus tachycardia is, y'all know this, according to me, slackers here. Who's slacking? We're missing 3 people. We got some sleepers in here? Yeah. I'm going on without you. Y'all did not miss that. About 160. At 160, you're right on the cusp of losing the view of the P wave. So there you go. All right. We're getting close to the end here, I think. WPW. Wolf, Parkinson, and White. 3 little doctors that got together and said, let's invent something new here. With Wolf, Parkinson, and White, this is usually a genetic disease. You know, people are born with it. We usually identify it in childhood. It may get through us, and we may not find it until they're older. But usually what we've got here is 2 pathways that are competing. And we'll usually see this because of a delta wave. The QRS is greater than 0.10. So you'll always see some kind of widening here on the QRS. The delta wave is this little slant that goes up to it on this particular one. So you usually recognize WPW because of this slope that goes up to the QRS complex. And your QRS will be a little bit wide because you got a different pathway there. Due to the ventricles stimulated by impulse originated outside the normal pathway. Yeah. So with WPW, kind of what happens is there's a blockage in here somewhere, and so the heart develops like collateral pathways to go around that blocked area for whatever, like a dead area, they're kind of born that way, and it doesn't go the normal pathway. So it builds its own little conduction system around it. And because of that, it gives you this wider QRS with that funny delta wave. All right. Yeah, here's your normal, you know, PRI. Here you've got this little delta wave where you can't really, like, see here you've got this little flat plateau that you measure as part of your PRI. Here it's not flat, it slopes up to the QRS. That's how you'll recognize that. Y'all okay with that? That was an easy one. Okay, clinical significance of our atrial rhythms. We've talked about this. Wandering atrial pacemaker, WAP. Usually your patient is not symptomatic from it. But if they've got that, it increases their risk of having other atrial dysrhythmias. Could be caused by digitalis. For digitalis, there's a very, very narrow therapeutic window here. And patients have so many different, they're dynamic, right, always. And so even though they've prescribed the correct amount of digitalis, if they're sick one day, it's going to change how that reacts. You know, if they lose some weight, it's going to change that. So there's a very small window there, and anything outside of that will become toxic for the patient, and it presents in so many different ways. All right, PACs, remember, premature atrial contractions, y'all don't leave yet. Usually they're not significant unless there was a whole bunch of them. Then a whole bunch of anything can be a problem. If there are a whole bunch of them, you're usually going to indicate some type of heart disease for your patient, but an occasional one usually doesn't indicate anything. Atrial flutter. Your treatment is going to depend, as all your treatment, on how symptomatic your patient is. If the conductive rate is normal, then you're probably not going to see any symptoms. If it's very fast, then you get a decreased cardiac output, right? So with this, we may consider there may be some medication. You know, digitalis would be one that you might use. We don't carry that. We may cardiovert them if they're unstable. Before you cardiovert a patient, you should try to sedate them if possible, because it can be unpleasant. We can try it on you guys if you want. AFib, we have what we call controlled AFib, meaning the rate is within normal limits. We call uncontrolled if it's really fast. And if it's really fast, then we're looking at how symptomatic your patient is. And if it's really fast, then we're going to have to look at managing it. Because if it's really fast in there and there's a lot of blood swirling around, we increase the risk that they could get a blood clot. If with atrial fib, because it's not coordinated, we're not getting a good feeling of the ventricles sometimes. You know, you're not getting the blood flow. The blood's supposed to move. 70% of the blood from the atrium moves by virtue of gravity down into the ventricles. Well, if it's being swirled around up here, it's not passing normally to the ventricles, and we call that the loss of the atrial kick, which also then will decrease the cardiac output. You guys figured that out. SVTs, you know, we see this quite commonly in perfectly healthy, normal people. And it's usually proximal, it just comes on, they'll zip off, you know, a couple runs of SVT and it goes away. Sometimes something simple like, you know, bearing down, some vagal maneuvers will fix it. Sometimes if they have a problem with it, they'll go in and work on this surgically. You know what they do? Yeah, they do an ablation. They'll identify where that ectopic focus is and they'll just like kill it, like that. They'll shock it. Your patient may say they feel like their heart's racing. You know, and you try to feel it. If you're feeling a pulse here and they're in SVT, what's it going to feel like? It's going to feel very weak, won't it? Of course it's going to feel fast, but it's going to feel weak because of why? Yeah, the pressure's going to be low. We've got severely reduced cardiac output because the ventricles are not able to fill. So we will treat this patient if they are symptomatic, but they're still alert and oriented. We're going to do what? The V word? Yeah, vagal maneuvers, Valsalva, one of those. So try some vagal maneuvers. If that doesn't work and they're still symptomatic but still good mental status, then what? Adenosine. If adenosine doesn't work, what kind of cardioversion? Synchronized cardioversion. Okay. Remember with your atrial rhythms, you want to identify, if you can, the underlying rhythm, like sinus rhythm with PACs, because it is a sinus rhythm. Okay, now I've got a bunch of strips, just like we did last time. So get ready. I want you to look at them and identify them. All right, what's this? Go down your list of 5 things. The rate is what? It's bradycardic, right? The rhythm, regular, irregular. P waves? Are they identical? Okay. All right. Select it. I should be all over this one. I'll start with the easy ones, you know. Okay. What about this strip keeps it from being normal sinus rhythm? Number 1, the rate, correct? It's bradycardic, so it's not a normal sinus rhythm. For it to be a normal sinus rhythm, the rate has to be what? Between 60 to 100. Okay, what else keeps it from being a normal sinus rhythm? The P waves are variable. What about the PR interval? It's too long, yeah. So we know it can't be sinus rhythm. How do we know this is not AFib? Yeah, this is regular. This is wandering atrial pacemaker. Every P wave looks different. It's still pretty regular though, but all the P waves are different looking. Okay, what's this? Use your clicker. Don't tell me what it is. All right, let's see. Is this 4-to-1 conduction or 2-to-1? Ta-da! Good job. Who picked atrial fib on there? Atrial fib has to be, number 1, what? Irregular. I mean, that's probably the most regular rhythm I've ever seen up there. All right, what's this? I should have put on there. I pulled a lot of answers. stab at it. Everybody's waiting for you. I'm missing 4. Now, what would it have to be uncontrolled atrial fibrillation? Uncontrolled indicates what? The rate. Remember, regular AFib is going to be under 100. Uncontrolled AFib is going to be over 100. So we know it's not going to be that, right? Can you see any P waves in there? It's just gibberish, isn't it? And it's irregular, right? Yeah. All right, what's this? Is it easier to see there, isn't it? Let you look at it there for a minute. Sometimes it's easier to see when it gets smaller like that, isn't it? Oh, why is polling closed? Because I backed up. All right, start over. Y'all didn't know I could do that. Just learned that last night. Come on, a few more. We'll be here all day waiting on 24 people to push their buttons. Aha! Everybody picked different things. Now, this could be atrial fibrillation because it is what? Irregular. However, it has P waves. If it has a P wave, it is not AFib. So we can mark that off. What else we got? Sinus rhythm with PACs or premature atrial complexes. Remember, I told you have to identify the underlying rhythm. You will say, it is a sinus rhythm. If you pulled out those PACs or put them where they should be, you've got a sinus rhythm. It's just not normal. So it's sinus rhythm with PACs. All right, keep rolling. When you're trying to figure out what these are, use your rules over there. Oh, come on, guys. It ain't that hard. Let's see. How do we know this is not sinus tach? 2 reasons. Number 1, the rate. Number 2, no P waves. Good job. Who said atrial flutter? Okay, what we got here? Man, she's giving us hard ones. Oh, one last one. Okay. Who's right? Can you see a clearly defined P wave on there? Is it irregular? Yeah. Even though this doesn't look messy like a lot of your AFibs, you still can't really identify a P wave, you know, that's consistent through there, and it's definitely irregular. If this were if this were sinus rhythm with PHCs, that means premature atrial contraction, right? These are pretty regular. Here, there's this elongation here, right? So that wouldn't be a PAC unless we got 3 PACs in a row here, which we won't have. All right, what's this? Top. This was easy. I'm missing 4 people. We got 4 sleepers in here. Who are you? Somebody woke up. Second most selected was atrial tachycardia. For it to be tachycardia, what does the rate have to be? Over 100. Does this look like it's over 100? No. So, I mean, any one of these rules, if it breaks that rule, you got to throw it out. So the first thing I do is I count the rate here, you know, and it's not over 100. It's irregular, right? The sinus brady, is that regular or irregular? It's a sinus brady, it should be regular. So it's not atrial tachycardia. Sinus rhythm with PACs. Where is the premature atrial contraction? Right there. These P wave, P wave, P wave, all those look alike. This is funky P wave, and it's early. And you can tell it's early because if it was regular, it should have been over here somewhere. So that makes it early. All right, here we go. What's this? Couple more, come on, man. Good job. Most of the time, you got a 2-to-1, 3-to-1, 4-to-1 conduction, but not always. In this case, you can see a couple of complexes. You know, this is irregular because they're done differently. I mean, they are conducted at a different rate. All right, what's this? Everybody voted it. Okay, why is this not sinus tac? No P wave and too fast, pretty much. And AFib is always irregular. Is that irregular? No. So guys, you got this is. I think this is 2 people, 2 people. So think about your rules. You got if it's irregular, then it might be one of those. But this is regular, so it's going to cut out some of this stuff. SVT, rate, no P waves. Maybe some of you guys think this is a P wave. This is not a P wave. Number one, if it were a P wave, it'd be a lot closer. This is a, it's the repolarization going on here. T wave, thank you. All right, what's this? Oh, this was too easy. What else should I put in there instead of tachycardia? Should call this sinus brady, shouldn't I? different P waves. Look at these myself. Here we see a P wave, here we don't. Not really here, there's a P wave, there's one. Some of these look consistent, but two of these don't. So that's going to be, gives you a wandering focus here. Ta-da! Okay, before you go, your workbooks, next Wednesday, you've got to do these 2 chapters. We're going to check those rhythms in the back. So I want you to identify those. Make sure you put if it's sinus rhythm with something or not. Measure them out. Fill all those out. You'll be graded on that. Next week, I think we're going to be doing junctional rhythms. So make sure you read that.
Did you check the first 6 chapters of the workbook?
Yes, Nick did. You can run down there. And we want you to head up that test.
Yeah, I got it.